Hello, everybody. Welcome to another edition of the Neonatal Brain Club lecture series by the Department of Neonatology at Cleveland Clinic Children's Hospital. My name is Shri Karnadi. I'm one of the neonatologists here. And today's talk, it's very exciting. As all of us know that not just underlying pathology that can impact the neurodevelopmental outcomes in preterm infants, there are more than that. There are other factors which will impact this. Today's speaker is an expert in dealing with this problem. So it's my pleasure to introduce Dr. Bobbi Pineda, who is an assistant professor in the Chan Division of Occupational Science and Occupational Therapy, University of Southern California and Keck School of Medicine. Dr. Pineda worked at WashU before moving to California. She's the author of the SENSE program, which we are going to hear shortly. And also, she worked on the neonatal eating outcome assessments. And Dr. Pineda also serves as a co-chair for the Neonatal Therapy Certification Board. So her team's focus, the research focus is to improve the healthcare delivery system for preterm infants requiring the NICU hospitalization, and also to identify various strategies to optimize neurodevelopmental outcomes in these high-risk infants. Her research findings from her research highlight the important role of the parents, especially in shaping the developmental trajectory and importance of the early sensory environment in the NICU, and also changing the landscape of early neurobehavioral and feeding performance in the NICU, and early therapeutic interventions that can improve these outcomes. Dr. Pineda's personal journey as a NICU parent, as well as her training as an occupational therapist and her role as an investigator, fuel her passion for improving the infant and parent outcomes for those who journey through the NICU. Without much delay, I invite Dr. Pineda to take this virtual podium.
Thank you, and thank you so much for the invitation to be here today. I also am very excited to see a lot of familiar names and faces on the line, and so thank you for joining and giving me the opportunity to speak about optimizing the NICU environment. Let me just get my slides up. Okay, so hopefully we're okay here.
Yeah, great.
Wonderful. So first, just a disclosure that I am an author of the SENSE program, or the Supporting and Enhancing NICU Sensory Experiences program. I do want to acknowledge that this is currently sold to clinicians and researchers, but it's sold at cost. And it's really the money that comes in for the SENSE program is really just to allow for the distribution and availability of it. But there is no direct financial benefit to myself. So first, I'd like to talk a little bit about neonatal therapy. I am an occupational therapist by training and was able to practice for 12 years in pediatric practice, with a lot of that in the neonatal intensive care unit as well, before I went back to school to get my PhD. And I really feel like it's that practice time that really helped me have a good understanding of the NICU and of therapeutic interventions within this population. So you currently know, and it seems like there's a little bit of background noise, so if everybody could please mute themselves, that would be wonderful. Currently, the AAP recommends that there's an OT or a PT in level 3 and 4 NICUs, as well as someone with neonatal feeding expertise. And I think this is really a response to understanding that there's a lot of developmental needs among the population within the NICU. We've also been able to do some research looking at neonatal therapy staffing. We have a manuscript that's actually been submitted for publication, and within it, we looked at NICUs across the country And we were able to identify that there's an average of 1 neonatal therapy FTE for every 18 beds. So that's an average. Of course, there's a range and there's a lot of variability. So some NICUs have no therapy. Others have up to 16. So there is a large NICU with actually 16 neonatal therapists on staff. There also are significant differences in team makeup. So some have OTs, some have PTs, some have speech language pathologists, some have all three, but the makeup of these different teams across the country also differ drastically. And then the neonatal therapist, like really it's a growing field. So there's more and more OTs, PTs, and SLPs working in US-based NICUs. And this seems to also be happening worldwide. So there's more in Qatar and in India and Australia. It is an advanced area of practice. And so the skills and the knowledge that we get within our basic training in our therapy programs doesn't really prepare us for being a therapist within the NICU setting. But there are advanced opportunities available for clinicians, and there is actually a certification now that helps to validate that you've kind of gone above and beyond to get that experience and knowledge so that you know how to interact appropriately and therapeutically with high-risk infants in the NICU. And then also, I just want to acknowledge that also psychology and music therapy is becoming more prevalent within US-based NICUs. So when we look at therapy approaches, I like to break it down into two different ways. It just helps me kind of organize things in my own head. So there's the rehabilitative approach, and then there's also habilitative approaches. And so our rehab approach is really appropriate for those babies who have lost function in some way, because it's therapy aimed at helping them regain skills, abilities, or knowledge that has been lost or compromised. So maybe the baby had a grade 4 IVH, or maybe cystic paraventricular leukomalacia, or some other happening within their medical journey that has then changed kind of like their functional outcome. So the rehabilitative approach is going to come in and either help them regain those skills or give compensatory strategies to help them kind of overcome and continue to be functional. Then there's also the habilitative approach. And these are healthcare services that help you keep, learn, or improve skills and functioning for daily living. But really, it's about a focus on building new skills and functions, not just restoring ones. So it doesn't mean that there has to be some level of impairment that caused the baby to be impaired. It could be that you're just fostering this appropriate environment and helping with strategies to help them have the best life moving forward. So talking about preterm infants, which are really the main focus of the research that I do, we know that it varies from year to year, but approximately 11% of infants are born preterm in the US, and this can amount to approximately 500,000 preterm infants annually. So there's a significant number of infants that are really impacted by preterm birth. With advances in medical care, there are increasing survival rates, and we're seeing that threshold of viability push lower and lower and lower. It's not uncommon now to see 23-weekers, 22-weekers even within the NICU. However, the amount of morbidity really has remained fairly stagnant. So even though these babies are being saved, many of them continue to have developmental challenges later in life, and hence the real need for neonatal therapy and then therapy beyond the NICU as well. And then I also just want to acknowledge that, of course, there are other populations within the NICU too, beyond just preterm infants, many of which also necessitate therapeutic interventions. So we know that our preterm infants have high rates of developmental morbidities. In the literature, you can see it oftentimes is classified as just a developmental, anytime you see global developmental delay, where they can have cognitive, motor, and language impairments. Also, there's higher rates of cerebral palsy, of ADHD. There's more and more research showing that a lot of these kids have behavioral alterations. So as they start to enter school, especially just having issues with managing their behavior, also interacting with peers. They can have sensory processing problems where they don't pick up on sensory environment sensory information within the environment in the same way as other children. They may be hyporeactive or hyperreactive. And these sorts of things can also lead to problems with interacting with peers. They also have, there's more and more research showing problems with social emotional health. Sometimes even children who go long periods of time really not showing any significant problems related to their preterm birth enter into the teen years, and then they can have issues with depression and anxiety. And there's also more and more literature showing that they're at a higher risk of psychiatric conditions. We also know that the lower the estimated gestational age at birth, the higher the risk of impairment. And with tools that we now have readily available to us, we are able to identify developmental impairment prior to NICU discharge. So in many of these cases, it's not that the developmental impairment happens later on, at 4 months or at 6 months or at 9 months, but it already exists during that time within the NICU environment. It can be detected, and there are specific interventions that can be started in order to help to ameliorate them. There are a lot of different tools that are available to assess early function within the neonatal intensive care unit, and those can include like the test of infant motor performance, the ENDS, the preneuro, the NBAS, the Hammersmith or the Dubowitz. Also, the general movement assessment is gaining a lot of traction for use of specifically looking at CP. There's also feeding assessment. So the neonatal eating outcome assessment and the NOMOS are also tools that can be used specifically during that neonatal period. And then, of course, there's more as well. But I also want to acknowledge that there is a challenge with early infant assessment, and that a lot of the tools that we consider our gold standard later on in childhood, like, for example, the Bayley scales of infant and toddler development, don't really discriminate function early on, and many of them you can't really assess during that early neonatal period prior to NICU discharge. So many of these tools are actually very specific for the population within the NICU. And then once infants are seen in newborn follow-up clinics and beyond, we need to switch to a different repertoire of developmental assessments. The other thing that's really cool about the assessment tools that we have available to us now are that many of them you have to use closer to term equivalent age, when the baby can tolerate more significant handling and many times has come off their respiratory support. But there are tools like, for example, the preneuro that you can use on the earliest time periods, even when babies are still intubated, and it can provide invaluable information to the clinician to know what sorts of interventions they can do at that time period. So we take this information from these early standardized neurobehavioral assessments or feeding assessments, and they really help us to understand whether an infant has developmental challenges or doesn't. So are they falling into a normal developmental trajectory, or are they falling off of that trajectory? And so it really helps us identify, number one. And then number two, especially on the more comprehensive assessments like the ENDS and the MBAS, it really provides a wealth of information that can help us really target specific interventions. So it's going to help us understand if the problem is with tonal or postural control, or if it's with self-regulation, or if they have problems with attention or handling stress within the environment, or if they're asymmetrical. So there's a wealth of information that can really be gathered from these neurobehavioral assessments, and they can really help us target those interventions. The other important thing is that we'll talk in a minute about how the brain is changing so rapidly during this time period, but neurobehavioral performance also is. And also the whole system is just very pliable. And so it's also very important that we continue to do reassessment on a routine basis so that we can then update the therapy plan. There are a lot of different factors within the literature that have been related to poor outcome among our preterm infants. And they include things like a PDA or NEC, those are related to outcome. Also longer periods of endotracheal intubation, or if the infant has BPD or chronic lung disease, that can also be related to poor outcome. Also, if the infant became septic when they were in the NICU. And then, of course, cerebral injury has also been related to poor outcome. And, the ones that we more specifically look at are grade 3 and 4 IVH, although a grade 1 and 2 can also impact outcome. Also, cystic paraventricular leukomalacia, and then also cerebellar hemorrhage can also be related to poor outcomes. Our team has specifically looked at length of hospitalization and controlled for medical factors. And we are finding some significant findings that the length of hospitalization also can be related to poor outcome. And ultimately, what I want to talk about today is the environment, because I think the environment is gaining more and more attention as a possible contributor to this poor outcome. And the great thing about the environment is that it's modifiable. So there's a lot of things that we can do as clinicians to help to optimize the environment and thus optimize neurodevelopmental outcome. So this all leads us into a habilitative approach. And so sometimes it's not necessarily that there's a specific cerebral injury and an impairment that needs the therapeutic interventions. But sometimes it's just that the overall environment, really for all babies, needs attention because it's an altered environment. And so we hear these terms: developmental care, neuroprotection, neuropromotive care, and all of these are really aimed at trying to optimize the environment for the high-risk infant. And we know that also, if you're born less than 30 weeks gestation, the average length of stay can be, upwards of 3 months. And so 3 months is a significant period of time during a significant period where the brain is really changing rapidly. And so it's a great opportunity to really work on this modifiable factor. So one of my favorite illustrations to demonstrate the changing brain is when we look at cortical folding. So we know that at 25 weeks post-menstrual age, the brain is fairly smooth with very few sulci and gyri. By 30 weeks, the cortex starts to fold on top of itself, increasing its space and also its complexity and organization. And so then it continues to fold on top of itself so that by term equivalent age, it really looks nothing like it looks like at 25 weeks. And I think the other interesting piece of this is when you compare it to an adult brain. And, we do see changes from term equivalent age until adult life, but it's really nothing like the amount of change that you see from 25 weeks post-menstrual age to term age. And then again, periods of rapid change are really windows of opportunity. And so we have an opportunity to really change the outcomes for these infants. And then also when we look at early brain development, we know that subplate neurons reach a peak between 24 to 32 weeks, a time that many of our preemies are sitting in the NICU. This is important in neural circuit formation and really are the first cortical neurons. And then neural circuit formation occurs in the second to the third trimester with synaptogenesis, axonal growth, and neuronal migration. And then the other important piece of this is just this whole phenomena of the generation of electrical activity. So some things happen more at the molecular level and are kind of like programmed to happen. And then other parts of brain development are really dependent on the amount of activity and sensory exposures that infants have around them. And those sensory exposures actually drive electrocortical activity that send this whole cascade of activity that happens within the brain and really changes structure. And so with the generation of electrical activity, there can be structural plasticity, axonal sprouting, and also changes in the number of dendritic spines and synapses in the neocortical neurons of the primary sensory areas. When we think also about what's happening during a pregnancy in the second and the third trimester, there's very likely this regulated, appropriate amount of sensory exposure that's happening during this period of rapid brain development that allows it to happen in its normal pathway. And so during the second and the third trimester, we know that the baby is moving in a fluid environment. They also become increasingly cramped into flexion as that third trimester unfolds. So they're cramped into flexion physically, and then also the central nervous system is really mediating that flexion, kind of telling them flex, flex, flex. And if we look at a lot of our neonatal reflexes, they're flexion oriented. Also, they're getting vestibular stimulation, not only from moving around within the amniotic fluid, but then also from the movement that the mother does within her environment. There's also tactile stimulation from all around within the uterine space. They're supposed to be shielded from light. And then also there's noise and language exposure. However, it's at lower frequencies because it's buffered by the uterine wall. And then during this period of the second and the third trimester, there's just lots of growth and maturity of vital body systems. And then, of course, there's also all of this rapid brain development that's happening. And when we compare this to what happens to our infants that are born preterm, it's quite drastic. So instead, they're oftentimes laying in these extended postures. They're exposed to a lot of painful stimuli. They're not getting human contact and touch and nurturing many times. And the whole sensory experience is just very different. The NICU environment has been described as noisy and chaotic, bright. The baby gets painful procedures. They're separated from their parents. There's also this lack of constant movement, and really vestibular is one system that is really underrepresented within the literature, and hopefully we'll learn more and more about that power of vestibular input. There's also decreased tactile input and then decreased positioning and flexion. And then really, as with all hospital stays, the babies are also susceptible to interrupted sleep from what's going on in the environment. So our group, led by Jillian Smith, studied stress in the preterm brain a couple of years ago, or a number of years ago. 55 preterm infants, less than 30 weeks, were enrolled, and we used the Neonatal Infant Stressor Scale, which is a novel scoring system that really allows you to look at cumulative exposure to potential stressors as identified by healthcare professionals of things that are stressful for preterm infants in the NICU. And we then did an MRI at term equivalent age, and then the ends to look at neurobehavior at term equivalent age. And what we found is that preterm infants were exposed to an average of 18 procedures a day in the first 2 weeks. And if you think about that period in the first 2 weeks, that is the most vulnerable, usually where much of their medical compromise is happening, also where the brain is the most immature during their period of time. And then also, interestingly, preterm infants were exposed to a number of stressors, but it was variable. So like if you had 2 infants with relatively the same clinical course, one could have a significantly different number of these stressful exposures than the other, despite the similarity in their clinical course. So that kind of tells us too that there may be some opportunities for modifying the amount of stress within the environment. And then even after controlling for brain injury, immaturity, and severity of illness, stressors in the NICU were associated with impaired frontal and temporal lobe development, altered diffusion measures, altered functional connectivity in the temporal regions, as well as abnormal motor behavior at term equivalent age. So really reducing stressors in the NICU is important neuroprotection and is really important. And I think that NICUs across the globe have really put in great efforts to try to reduce stress to high-risk infants. This includes reducing noxious stimuli, also reducing sensory exposures that are too intense for the infant to handle. There was a time where playing music within the NICU and having more loud conversations and different kinds of stimuli that these infants weren't able to handle did happen in the unit. And I think we've made great progress with really trying to decrease stress. Also, it's important that we provide supportive neuroprotective strategies. Private NICU rooms are one way too that we've really been able to reduce the amount of stressful exposures because it allows us to more so individualize the sensory exposures that infants get. So rather than if the infant next to that baby is, screaming and having a really hard time or their alarms are going off, usually every baby in a barn-style room is privy to that, whereas in the private room, it really requires more intention. You're either turning the lights on for that specific baby or off for that specific baby, and they're not privy to all of the sound exposure going on. But it is really important that we don't swing the pendulum too far. And I think with the advent of private rooms, it's really important that we're intentional in terms of what kinds of sensory exposures infants get. And so our group looked several years ago at the relationships of outcome related to the NICU room. And so we were in the perfect place to do this because in this NICU, half of the beds were in an open ward and half were in private rooms. So same hospital system, same procedures across the two units. And what we found is that infants in private rooms had poor outcome. So they had less organized electrocortical activity by term age. They also had less hemispheric asymmetry by term age. And then they had poor language and motor outcomes at age 2 years using the Bayley scales of infant and toddler development. These findings went completely against our hypothesis because we really thought that infants in the private rooms would actually thrive. Reductions in stress, having parents be able to come in and have those intimate moments with their baby during the early time period, we really thought it would have more of a protective factor. So these were very surprising. From this, we hypothesized that diminished sound and language in the private room may have been an issue, and that potentially infants could be missing important exposures during a critical period of brain development. We also specifically looked at infants who had brain injury versus not. And interestingly, they had the highest effect size. And so if you had a brain injury and you were in the open ward, you'd scored an average of 18 Bayley points higher on the language outcome than infants who were in the private room. We then wanted to learn more about what was going on in the auditory environment within our NICU. And so we looked at sound exposure in the private room compared to the open ward. And we used the LENA, or the Language Environmental Acquisition Device. And what we found is that, yes, there was more silence in private rooms. And by term equivalent age, this was an average of 3 hours more. There was also more noise in the open ward. And we also learned that medical procedures can be quite noisy, specifically high-frequency oscillatory ventilation. But then also more parent engagement was related to increased language exposure. And I think it's also to discuss context. And so not every NICU across the US is, of course, the same. There's different types of families that have different kinds of social challenges across them. And specifically in our NICU, which was in urban St. Louis, we do have a large number of families of low SES with decreased parent presence. And so ultimately, in hindsight, when you look at this, you see infants that are in the private rooms for long periods of time. And so what happens is usually cares happen about every 3 hours. And so the lights go off and the baby is left for 3 hours, kind of in this dark, quiet environment. The nurse comes back at that 3-month mark, or 3-hour mark, to do her cares with the baby. And she might turn on the light so that she can actually see, but she's trained in developmental care strategies. And so she keeps herself fairly quiet, doesn't really engage with the infant, changes the diaper, does the vital signs, and then turns and feeds the baby if the baby is fed, and then leaves the baby again in a fairly quiet and dark environment for another long 3-hour stretch. And so this is very different from NICUs that have families that come in and are actively engaged. So if you just if you think of kind of the context of these findings, I think it's very important. We also followed this up looking at auditory exposure in preterm compared to full-term infants. And so we compared those preterm infants in the NICU at term equivalent age to what is experienced by a full-term infant on the labor and delivery floor before they're sent home. And what we found is that there's 3 hours, 15 minutes less language in the NICU compared to the labor and delivery floor in a 16-hour period. And this amounted to 14,110 fewer words in the NICU. So already, just from this information, we can see that there's a significant language deficit among our preterm infants in the NICU. The other important thing that we've studied is maternal contact. And so the need for human contact and nurturing have long been understood. There are a lot of animal studies, and they have found that maternal separation can result in emotional disturbances and decreased motor activity. And in fact, some of these very early studies, the animals died, or they went on feeding strikes. I mean, it was pretty drastic, the impact that maternal separation had on them. Also, we know that orphaned newborns are less vocal, and early deprivation of social and caregiver interaction can have lasting effects with poor growth, developmental delay, and then also increased emotional and neurocognitive difficulties. So we also wanted to better understand our own context of families within our own unit. And so we wanted to really understand their parent presence and engagement. So we enrolled 81 preterm infants and their parents. And what we found is that parents were present an average of 4 days per week in our population. So this means that an average of 3 days per week, infants were really going without the comfort and the nurturing of their own parent. And that also parents held their infants an average of 2.8 days per week. So again, an average of more than 4 days per week, they weren't really being held in arms by a parent. We also found that more holding in a NICU was related to fewer suboptimal reflexes, less asymmetry, and better gross motor development at 4 to 5 years. And that was using the ASQ, which is a parent report measure. And then also skin-to-skin holding in the NICU was related to better reflexes, less asymmetry, and then better gross and fine motor skills. So brain development really relies on these early appropriate sensory exposures. They can modify the architecture and signaling of the brain and help with the development of an abundance of positive, developmentally advantageous synapses that really lay the foundation for later pruning for specialization. So it's extremely foundational for later development. And then those early sensory exposures can really drive appropriate neuronal activity. And again, this being a very important and powerful period of development. So as clinicians, it's really important that we mitigate stress to help to protect the brain, that we foster parent-child relationships to improve brain health and lay the foundation for all learning, and somehow empower parents to come in and engage with their infants. And then also it's important that we ensure sensory exposures that will optimize early brain development. So it's very easy to say these are all important things for brain health and for improving neurodevelopmental outcome. And I think all of us are really making great efforts to try to improve the amount of kangaroo care and getting families to come in and engage as much as possible. And even with FI care, really getting them to take on different parts of the care plan. But the whole implementation of positive sensory exposures every single day of hospitalization is lacking in many instances across US-based NICUs. So I think it's important that we ask ourselves, are we really doing these things? Are we encouraging parents to come and engage with their babies in a consistent fashion every single day so that they're really getting that power of parent engagement and positive sensory exposures to drive their brain development? And again, there's a little bit of background noise, so if everybody could please make sure they're muted, that would be wonderful. So the SENSE program really gives a choice of different tactile, auditory, visual, kinesthetic, and olfactory gustatory experiences to the infant every day of hospitalization in the NICU. It's evidence-based, so it all draws on current evidence. There's no rocket science here. It's all based on published literature. And then the doses are based on postmenstrual age. So it's acknowledged that sensory development happens at different periods of time. The visual system, for example, happens much later in development than the development of the tactile system. So it kind of recognizes this interplay of different senses and when they come on board. And then also it acknowledges that the amount of sensory exposure that's appropriate for an infant at 24 weeks postmenstrual age is very different from what's appropriate at term equivalent age or even at 34 weeks postmenstrual age. And so it really allows kind of this like changing landscape of what's appropriate. Also, it's based on infant tolerance and driven by the infant's behavioral cues. And then the whole goal of the SENSE program is really the aim is really for it to be parent delivered, to get parents to come in and engage with their infants and really form the foundation of that parent-child relationship. And so a lot of the program is really based on these parent education materials. There's also this opportunity for a sensory support team to come in and fill the gaps. And so it isn't uncommon for parents to need to step away from the NICU for a number of different reasons. They might have other children at home. They may have to return to work to save their time for when the baby comes home. And so there's opportunities for a volunteer or cuddler program to come in and fill in the gaps when the parents aren't able to be there. And the program can be tailored to infants with different medical courses, and then also can be tailored to different cultures. And so some hospitals might use the IVH bundle of care, and the baby cannot get out of the bed during the first 72 hours. So it can all be kind of tailored to the NICU culture as well as the wishes of the parent as well. It's intended to be incorporated into daily life within the NICU, and typically the program is overseen by a neonatal therapist who does the parent education and then also assesses the infant's tolerance of the program and makes any adaptations as necessary. So in terms of the SENSE program, it incorporates what we know to date on sensory experiences in the NICU and really recognizes the importance of decreasing stress, having appropriate positive sensory exposures, and then also the critical role of the parents at the bedside and really giving them tools and empowering them to engage with their infants. It also recognizes the individuality of each infant family system. And so some babies, again, are going to have varying degrees of medical complexity. And then also there's parent choice there too. So some parents may actually choose that they don't want to do kangaroo care. So what other choices in terms of tactile exposures can they draw from so that they can find their way as a parent and what they feel comfortable with? And then also, again, it recognizes these changing needs of infants across development. So we undertook several steps to developing the SENSE program. First, we defined current evidence. Then we got stakeholder feedback, which included experts, parents, as well as interdisciplinary focus groups. We then did a pilot study and an RCT. So the very first thing that we did in our process was really to draw on all of the data, all of the evidence on sensory exposures from the last 20 years. Specifically, we looked for data that was related to providing sensory exposures in the infants less than or equal to 32 weeks, specifically during the NICU stay. And we identified 88 articles. From this 88 articles, we were able to identify the different sensory exposures across all of the different domains. So for example, tactile as well as auditory, as well as kinesthetic. And then it also helped us with identifying the timing of those interventions. So for example, if the study was on massage, was the massage done at 32 weeks or 36 weeks postmenstrual age? Like what exactly was the timing of them? And then those findings have now been published in the Journal of Perinatology. And we do have a new integrative review on the evidence from 2014 to 2020 that is nearing completion, and we'll hope to have that done by the end of the year. And from that evidence, we'll continue to contemplate changes or enhancements to the SENSE program based on emerging evidence. The other thing that we did was looked at stakeholder feedback, and from the stakeholder feedback that we got from experts, we were able to learn that across the US, that typically interventions for tactile are done starting at 24 to 26 weeks, auditory at 30 to 32, kinesthetic at 30 to 32, vestibular at 33 to 34, and then visual interventions typically are started at 32 to 36 weeks, and those findings have also been published. We also asked parents what their thoughts were about having a sensory guideline to help to support them in doing age-appropriate, evidence-based sensory exposures to their infant every day. And we got a fairly positive response from parents, and they also gave us meaningful input about the use of like a sensory support team. And those findings have been submitted for publication. I'd like to just show a few excerpts of the SENSE program parent education materials that we use to guide. Well, it helps to guide the clinicians, but it really helps to also guide the parents in terms of what they can do. So there's a whole table of contents talking about parenting in the NICU, talks about the senses and really how they helped us to understand information from around us. What growing up in the NICU is like in terms of sensory exposures. And then there's a whole chapter 4, that's on how your baby talks to you. And so this is all about how the infant shows different kinds of stress and approach signs that can help guide you as to whether the baby's ready for the interactions that you're presenting to them. Also, there's a whole chapter on when to interact, talking about the importance of sleep and what sorts of things you can do to help your baby to sleep and what sorts of things you can do when the baby is awake. Chapter 6 is really the nuts and bolts of the whole program, and this is the week-by-week sensory plan that tells you exactly what you should do at 23 weeks postmenstrual age, what sensory exposures you can draw from, how long you should do them. And then chapter 7 helps to support that with a how-to guide. So it says that I can do massage. How do I do massage? Or it says to use a scent cloth. How do I use a scent cloth? So the first chapter, again, is on parenting in the NICU, and this is what you can do for your baby. It talks all about the importance of parents and that really the parents are irreplaceable and really the most important person in the baby's life. It talks about the baby's medical treatments and how you can continue to parent even when your baby is undergoing these medical interventions. Chapter 2 is all about the senses and talks about the senses broken down and then how they basically develop in utero, what sorts of things the baby is supposed to be experiencing at that period of time. Chapter 3, growing up in the NICU, talks about the NICU experience and how then the sensory exposure is a little bit different. One other thing I forgot to mention is that the whole SENSE program parent education materials are in a 5th to an 8th grade level, so put in language that should be easy to understand by all and accessible. There's also information about supporting your baby's sense of touch, supporting your baby's sense of hearing. And then chapter 4 is how to read and respond to your infant's cues. And so it talks about approach behaviors, the baby showing signs that they're really ready for interaction. And then self-calming behaviors, I'm doing okay, maybe meaning that they need additional support from the provider to get over some level of stressor that's occurring. And then there's also specific examples with pictures and words showing when babies are demonstrating a need to have a rest. And then chapter 5 is all about when to interact. So again, sleep is really important. There are things that you can do when your baby is sleeping. And then there's also things that you can do when your baby is awake. And then the meat and potatoes or the nuts and the bolts of the program is this week-by-week sensory plan. So it's broken down into touch, hearing, smell, seeing, and then movement and body awareness. And then you can see here, this is the one for the 23-week postmenstrual age infant. So for touch, you can choose kangaroo care or comforting touch with your baby for at least 1 hour per day. For hearing, you keep the area near your baby quiet, but engage in quiet conversations near the bedside and during diaper changes. For smell, place a scent cloth under your baby's head. For seeing, keep the lights off to protect your baby's eyes. Use a cover over the bed to further protect your baby from light. And then for movement and body awareness, giving your baby an opportunity for movement, at least 2 minutes prior to a diaper change 1 time per day. And then you can see as we progress forward, I jumped up to 32 weeks here. A lot more of a repertoire is added on at 32 weeks. So you can introduce massage at 32 weeks. You can also introduce music. And then also we start cycled light at 32 weeks postmenstrual age. And then you can see the dosage has jumped up drastically as well. So you're going to give at least 2 hours of touch each day, and you have more things to choose from there. You're going to do at least 1.5 hours of auditory exposure, and then so forth and so on. And then by 39 weeks, it jumps up even further with at least 3 hours of touch, at least 3 hours of hearing. With smell, we then hope that there's going to be more close maternal and paternal contact. We'll be cycling light, and then there'll be also more opportunities for movement at that period of time, as well as vestibular. And then the how-to guide is going to break it all down into how you do these different things. How do you do massage? How do you do gentle human touch? If you're doing kangaroo care, how can you do a stand transfer to help to decrease the amount of stress of the infant when they go from the isolette to the mother's chest? There's written materials that are all in a booklet where it's all in words, but then there's also electronic materials that can be downloaded onto a PC or an iPad or a smartphone, and it has embedded videos where the words are then supported by a how-to video as well. So the SENSE program was then piloted. So we enrolled 70 preterm infants, less than 32 weeks estimated gestational age. And what we found is that mothers whose infants received the SENSE program demonstrated higher scores on the maternal confidence questionnaire. And then infants who received the SENSE program demonstrated less asymmetry on the ends, and then higher scores on the Hammersmith. And those have now been published in the Journal of Early Human Development. We also did an implementation study just to help us understand more of those implementation factors. And we found that the SENSE program was initiated at an average of postmenstrual age of 29.8 weeks, which was 4.9 days after birth. The average number of educational sessions that was done with families to help to promote them to be able to do the program was 4.8. And each session, it varied, but some of them were only like 6 minutes long, some were 12 minutes, and some may have been like up to 20 minutes long. We also found that the total time of logged sensory exposures averaged across hospitalization was about 15.5 hours per week. And then when we compared this standard of care group to a SENSE group, we found that 91% of the SENSE interventions were done with that SENSE group, whereas only 48% with the standard of care group. And then 95% of infants tolerated the SENSE program exactly as it was defined. And this was fairly exciting to see because this was a level 4 NICU, that the majority of infants tolerate it without really needing any kind of adaptation. But of course, there are those infants who are a little bit more sensitive or need those adaptations. And then also one of our significant findings from this publication was that earlier parent education was related to more parent participation in SENSE program interventions. So if we could get to families right after the birth of their infant and engage them in providing positive sensory exposures to their infants each day of hospitalization and to really understand their role and the importance of them, it seemed to have a really profound impact. We then did an RCT where we enrolled another 70 preterm infants, and they were randomized to standard of care or the SENSE program. And we found that infants who received the SENSE program had more lethargy on the ends, and that was a little confusing. But then higher communication, which is also equivalent to language scores on the Ages and Stages questionnaire at 1 year of age. Some of the things that we also did was we surveyed families after they when they were part of the program to learn more about their interpretation of the SENSE program. And some of the things that they reported that they did not like about the SENSE program is that I frequently missed the volunteers during the day. The log, my baby needed me more and more. I did not have time to keep track of the activities because there is a bedside log that they can fill out with their activities. Also, there's not anything that I disliked about the study. Me and my baby have a great bond because of the study. XOXO Riley's mom. And then some of the things that parents reported that they liked about the program It taught me how to help my baby advance by the week, like how long to read, hold, rock, and play music to him. Great exercises and all types of activities with my baby that were very helpful. It showed me how to provide more care for my daughter. I loved knowing that someone could show my child they were not alone when I wasn't able to be there. And it gave me confidence to be involved. It also gave me practical ways to help and bond with Teddy. We also just recently did a survey of healthcare professionals who have implemented the program. So to date, we have about 270 hospitals across the United States. And then there's also some that are abroad that have purchased the Sense license and are working towards implementing or have already implemented it. And some of the feedback that we received from them just last month is this is an excellent program and the only one I am aware of that is immersed in evidence-based literature. It's straightforward and gives a name to things most team members are already doing. Parents have verbalized enjoyment in reading the parent guidebook and knowing what to expect in the coming weeks. I think it is a great program, love the educational materials. Vital part of our treatment. I'm very thankful for this resource and the implementation checklist that helped create a sustainable program. This program has made a significant impact on infant parents, caretakers, and staff. So in terms of future directions, we hope to, I was mentioning that we are hoping to finish a new integrative review, and then we'll tie that evidence into potentially any changes of the Sense program. We also hope to spend the next couple of years really looking at implementation factors and what sorts of things are barriers and facilitators to really optimizing the early NICU environment, and how we can really make this be a sustainable program that can impact more. Also looking at just the differences from one NICU to the other, really working on health equity across sites and access to services so that all infants and families can get therapy services that are warranted for them. And then we hope to improve the experience of being in the NICU and optimize neurodevelopmental outcomes of high-risk infants as kind of our long-term goal. So just a couple of acknowledgments. I do want to acknowledge the Washington University NICU Therapy Lab, which is now transitioned to USC, and then also all of the infants and families who participate in our research. And then thank you to Cleveland Clinic for the opportunity to come and talk to you today.
Thank you so much, Dr. Pineda. It's wonderful. I think a lot of people, they have questions on the NICU design as expected. So I'm going to read some of those. Especially the private room versus the open design. So what interventions need to occur in a single room to increase the language development?
Yeah, that's a really great question. So I think probably when parents are present within the environment, these things happen fairly naturally. There's a natural tendency to talk and engage with your infant. So I think just having more talking and engaging, but not at levels that would then be stressful for a preterm or a high-risk infant in the NICU. So keeping our voices down at or around 45 decibels, for example, with positive language exposure can be pretty powerful. I've also seen more and more reading programs popping up where, books are available within a library for the families or even for volunteers to come in and read. That can help to close that language gap that we've identified within our research. And then there's also a power of music, but music is a little bit challenging because for infants who are very early in their postmenstrual age trajectory, they're less mature in being able to handle the like constant nature of it. When there's human interaction and human voice, if an infant starts to show stress signs or even starts crying, there's this natural tendency to pause, help them kind of be supportive, and then to return to talking or engaging with them. Whereas music just continues to play. And so there's less of that reciprocal interaction piece. So that's the reason why we've kind of placed the whole introduction of music to happen a little bit later in the developmental trajectory. So not really describing it as something that's appropriate per se prior to 32 weeks. So really, music, reading, language exposure, and even when you talk about music, it can be a parent reading, singing, talking. There's a lot of different ways that you can implement it.
Great, thank you. I think this question is similar lines. How do we empower families to increase their interaction, especially in the presence of caregiver, healthcare provider, in the presence of, without the healthcare provider?
Yeah. So, having gone through the NICU as a parent myself, I think that there's just like a lot of parents not necessarily knowing what they can and can't do. And, when you have the medical team really being the primary one who's providing the care for your infant, sometimes it's just hard to like find your way and gain confidence in what you're doing as a parent. And so I think by just having tangible expectations, and maybe expectations is a hard word because we don't want them to feel like they have to do something, and that, I don't know, it doesn't need to have like a negative connotation, but instead, by just giving them tools, like we would really like for you to do gentle human touch or hold your baby skin to skin for this period of time, that can be extremely powerful for them, because then in many ways it kind of gives them permission to do that and to really engage and to feel part of their baby's life. And so I think just giving them things that you hope that they do can go a long way.
Great. This is about the results of one of your studies, the parental presence. Is there a difference between dad holding versus mom holding, or just a touch that matters?
So I don't know if there's really research that has differentiated the effect or the impact of dad versus mom. I'd like to think that both are very powerful, but we really don't have the research to support it one way or the other. So I think until then, it's really the touch that is what I would focus on.
Okay, great. This question, is the SENSE program in other languages also? What other languages it's available?
Yeah, that's a great question. We've actually been so impressed because there's been a lot of international interest in the SENSE program for different reasons, I think, even across different countries. It's currently translated to Spanish and available on our website in Spanish. And then there is a Hebrew translation that's almost done. There's also a Hindi translation that's almost done. And then there is a couple of others. So now I'm like drawing a blank. There's a couple. Oh, and I'm sorry. There is a Tetswana and isiZulu translations that are completed as well. And then I don't know, there's a couple of others that are actually in the midst of doing it. And our next hope is Arabic is one of the other ones that's being requested that we'll be working on.
Great. What evidence supports the dosing or duration of the sensory experiences?
And I'm sorry, can you repeat it one more time?
What evidence is there to support the duration or the dosing of the sensory experiences?
Yeah, that's a great question. So largely we pulled from the available evidence from the last 20 years. Studies do identify, that they did 15 minutes of an auditory exposure or 45 minutes of kangaroo care or continuous kangaroo care. So we kind of took the overall doses that were already identified in the literature across the different postmenstrual ages. And then ultimately from there, we asked experts. So experts in the field, and these were neonatologists, neonatal therapists, and then also nursing and social work also had representation within that.
Okay. How many people comprise your team for what a typical day sense is to implement this?
How many people comprise the team for the sense implementation?
For a typical day? I mean, again, depends on your number of babies there, but what is your typical number of people required?
So, I mean, I can draw from our experience when we did the RCT, and that we probably had around 10 to 12 babies at most in-house at a given time. And we had one sense administrator that basically went down and, again, did the parent education and, made sure that the baby could tolerate the program. And then we had, I don't know, maybe like 5 or 6 volunteers that would help to fill in the gaps when the parents weren't able to be there. From the implementation side, as we're learning more and more about NICUs that are implementing it, it seems like most are embedding the program within the neonatal therapy team. And most NICUs, I would say, have around 2 or 3 neonatal therapists. So they spread it out. So like, one therapist might do it with her caseload and the other one might do it with theirs. And then they function basically as the sense administrator. So they're already going down and doing therapeutic interventions with the baby. They're already educating the parents. They just educate them on the sense program as well. And then it kind of becomes embedded in their normal daily rhythm, I guess, for lack of a better way of saying it. But probably, I think that you were saying, is right. Like you probably need more people doing the sense administrator role in your higher volume NICUs that have 100 beds compared to a smaller 20 bed level 2, for example.
Okay, that's good. Do you get consent from the families before you enroll them in the SENSE program?
So I can only speak from the clinical research side, and yes, absolutely. Did a written informed consent shortly after birth. So our window was within 7 days, but we really shot for prior to the mom being discharged from the hospital because we found, again, more success with the earlier engagement that we could get them. So most of them were enrolled within 48 hours of birth. And in terms of like if you're implementing it clinically, that's a really good question. Do they consent the family? I imagine they're educating them on the SENSE program and giving them the opportunity to either participate in it or not, would be my guess from an implementation standpoint.
So it's the neonatologists or whoever is taking care, they are the ones who are responsible for that, or?
I would say most of the time, probably 98% of the time, it's actually the neonatal therapists who drive the program within NICUs. There's also some NNPs I know, and then nursing. And then there's one neonatologist in Florida that I know of that is the main driver in her NICU. But I imagine it varies across sites.
I think this is an interesting question. What developmental impairments are you expecting from the requirements of mask, especially with this new restrictions, COVID restrictions? Did you see any impairments? One from the mask usage as well as the visitation. I think the other one is the visitation. Yeah.
Yeah. And I mean, certainly these have been really challenging times and have led to, restrictions in parent visitation or presence, as well as the use of masks within the NICU. And I think, the short answer is that we can kind of like look at previous literature and think that these things are probably going to make a difference, but we really don't have the literature yet to support, what exactly has happened. I think certainly when parent engagement is diminished, we've been able to show that more parent engagement is related to better outcomes. So we would think that there would be an impact of that. And then the use of masks is just so complex because children pick up so many cues from facial expressions, and those are going to be masked, in this population moving forward. But I think we just have a lot to learn, and hopefully there'll be new data that will emerge over the next year or two to help us understand.
Great. The other question is about the late preterms. We have a big number of the premature babies being late preterms, which is 34 to 36. Do you have, I know that a lot of these studies are done less than 30, less than 32 weekers, or even extreme premature. Because the studies have shown even these are at risk for neurodevelopmental impairments, though majority of them, they do well. Do you have any suggestions for these? Because some of them, they don't come to NICU, they will stay in the nursery, but they're premature. So do you have any suggestions, or are they included in your studies?
And I think especially when the environment is altered, so they're not going to their home environment, I think it's really important that we're just very cautious and intentional with giving positive sensory exposures. But the program really goes up to 40 weeks postmenstrual age or term equivalent age. So it can be applied to infants who are also in newborn nurseries. And really, it can also go home with the parents too, just to help drive them with appropriate sensory exposures they can do with their baby if they get discharged at 35 weeks, for example.
Okay. I think there is one request is like other than Spanish, like a Kurdish. I think there's a large population in Nashville. I think they would like to have it in Kurdish language too.
Kurdish, okay, we'll make note of that.
And then Dr. Costa from Brazil, I think shared this experience. I have been using OKN and VIVO-R eye movements to detect neurological impairment outcomes, and they have been very sensitive in categorizing cortical blindness, subcortical damage, something he's sharing. And also preterm babies frequently show temporal leukomalacia affecting the temporal lobe, impairing their future language development. Something interesting. I think those are our questions. And how is it available? Like, where can they access this program, SENSE program? It's coming, is a website?
Yes, I actually don't have a slide for the website, but if you just Google University of Southern California SENSE program or even Pineda SENSE program, it should pull up the website that they have at USC, which is distributing it currently. And then you can just kind of follow along. You can buy just the parent education materials or the whole implementation system, and then it gets sent out to you.
Okay, perfect. I think it's probably one last question. Any studies comparing outcomes between the NIDCAP and the SENSE program?
There are no studies available comparing NIDCAP and SENSE right now, maybe in the future. But, I also like to say that I really think of NIDCAP as being foundational for the SENSE program. And I think it's also important that we continue to sort of bridge off of previous work. And, the work of Heidi Sauls is just phenomenal in how she's really helped us understand early infant behavior and not just to plow through interventions without paying attention to what the infant is telling us and what they can tolerate. And so I feel like the SENSE program has really taken her foundational work and now is just kind of trying to bridge into ways to give parents more specific information on sensory exposures to do in that light across postmenstrual age that's evidence-based and appropriate. And the doses really help to then drive them in understanding whether they've met it or not, more than anything. So I like to think that NIDCAP is foundational for this, but maybe in the future we can look at additional work comparing different strategies.
All right, one last question. He's my colleague who is driving. He wants to ask a question. He can't type. Please go ahead, Dr. Das.
Thank you for the great presentation. I'm Ani Das. I'm one of the colleagues of Dr. Shri. So my question is, in Cleveland Clinic, we had a parent show up rate, I mean, if you call it that way, to our NICUs at about 5 days a week. And we demonstrated that actually parents do log in to their webcams very often. So we found that it was very useful for parents who were at a distance from the NICU, who were, in a lower socioeconomic strata, corroborated by their insurance status, and also their mental health. Like depressed parents won't come in. So did you think of, or have you used technology to improve the sensory experience of infants, meaning the webcams, bedside webcams, meaning parents having their talks recorded or their voices recorded and stuff like that?
Yeah, that's a great question. So to kind of answer your last thing, yes, there's the opportunity to play the mother's voice, or to record the mother's voice and then to play it back. Typically, we use iPads to do that because it just seems to be the easiest way these days. But then in terms of other technology, the use of the webcams, and it's exciting to hear that you're having people log in and use that technology, because I think it's a great way for the parent to be able to kind of stay in touch with what's going on if they're not able to be in the NICU. We had not used it during our studies that were at St. Louis Children's, but we actually hopefully will get some grant funding in the next month or two, fingers crossed. And in that one, we're actually hoping to leverage the bedside cam in the hospital, the study site hospital, where we'll be able to better even quantify exactly what's happening in terms of sensory exposures, because definitely like capturing sensory exposures is a challenge. Oftentimes it relies on documentation that may not always necessarily be accurate, either by the parents who, decide to prioritize something else, rightfully so, than logging what they're doing. And then also in terms of nursing documentation, nurses document a lot of different things. And did they consistently document that the parent put the baby skin to skin, for example? So leveraging technology from a research standpoint, like the bedside cam, can actually be extremely insightful. And we're really excited to be able to hopefully do that, again, God willing, with grant funding. And then in terms of other technology, we are hoping to come out with an app. So actually we have a version of the app right now, but we have some issues with it. So we're now reconfiguring it. And the app will allow for parents to be able to access the parent education materials on their own phone or whatever tablet that they're using. And then also we'll be able to give them a space to be able to track what they're doing. And it'll also tell them, it'll quantify for them. So, 30 more minutes of tactile exposure. You can do it in a number of these ways, or you need 20 more minutes of reading to your baby today. So this will allow them to kind of like do tracking and then quantify it so that it can kind of give them an opportunity to be able to do more. So we're really excited about that. But those are the main ways that we're looking at the use of technology at this point. But that's a great point. So I appreciate you bringing that up.
Those drive safe.
Thank you.
Thank you so much,
Right.
Dr. Pineda. It's a wonderful talk. Everybody enjoyed. I'm looking forward to more talks from you in future.
Thank you so much for inviting me. I really appreciate it.
Yeah, have a wonderful weekend. Stay safe.
Thank you.